Assalamu alaikum. Thanks for organizing committee to invite me today, Dr. Weil, and all the committee. I'm very privileged to be chaired by my mentor and my teacher, Dr. Muhammad. Welcome, Dr. Muhammad, and also Dr. Nasri, my friend. So in coming 15 minutes, I'm going to talk about the new emerging treatment for CKD. If you look for as a nephrologist, my colleague, they know, for the last 2-3 years, we don't have a lot to add for CKD apart of RASI. For the last 2 years, we have a lot to do behind the CKD in order to slow the progression of CKD. So in next 15 minutes, I hope to finish this my disclosure, nothing to disclose. I'm going to do some presentation, including introduction about epidemiology and the crisis of CKD, some screening and management of CKD, and then my core of the talk will be concentrated about the emerging treatment, basically the use of SGL2, non-steroidal MRA, and GLB, about the future for CKD. So, as mentioned earlier, CKD is a common global crisis where approximately 1 in 10 globally, they have some sort of CKD between stage 2 to 5, where we need to act more and more in order to decrease the prevalence of CKD. You know, CKD associated with increased mortality, increased morbidity, increased hospitalization. The patient with CKD have higher mortality, at least twice than the other with no CKD. And this is a data from WHO, which showed among non-communicable disease like respiratory or cancer, the CKD will be the higher prevalence in coming years. Furthermore, about 12 years ago, the CKD was number 19 of death, now is number 10. And in 2040, as per WHO, if we don't act now, it will be number 5th of death among all other diseases. Looking for some epidemiology we did in Saha Kidney Care in Abu Dhabi, done by my colleague. We looked for approximately 2 million blood tests done in about 5 years of ambulatory health care, the primary health care. And what we found among all entire cohort, the prevalence of CKD, looking for age, nationality, and gender, there were 1 in 5 individual in Abu Dhabi, they have some sort of CKD between stage 2 and 5. Luckily, most of them is stage 2, where a lot strategy need to be done in order to detecting those patients and early intervention to avoid progression. This is the visual slide for this study. If you're interested, you can look. Being high prevalence of CKD, we at Saha Kidney Care conducted at least annually or biannually some sort of workshop for primary health care, and we elaborated this algorithm from international guideline in order to early detection, screening, and intervention for CKD patient. As mentioned earlier, they are linked together, cardiac, diabetes, and CKD. And we know 40% of CKD is due to type 2 diabetes. Furthermore, up to 60% of people with CKD, they have some sort of cardiac disease. Up to 16% of people with heart failure, they have type 2 diabetes and CKDs. They are all linked together, cardiac, metabolic, that's diabetic, as well as kidney. And if you look for CKD patient, people above 65 years with CKD are 6 times more to die from cardiovascular before they progress to CKD. In fact, as a nephrologist, we said if patient reached to dialysis, he's lucky that he's not died because of cardiac disease before he reached dialysis. And in a statistic way, if you have 100% patient with CKD of stage 3 and less, approximately 70% will die from cardiovascular before reaching dialysis. As mentioned earlier, the American Heart Association late 2023 advisory board come with what we call cardiovascular kidney metabolic, and this is a syndrome where it's a health disorder due to connection among heart disease, kidney disease, diabetes, and obesity. And there are 4 stages, nicely elaborated by my colleague, Dr. Anwar, started by obesity and ended by cardiac, kidney, and all peripheral vascular disease, even at CNS and CVA involvement. You know, CKD is a silent disease. For that, we need to screen of it. And the international guideline emphasize in any patient who had high risk of CKD, those with diabetes, those with heart disease, those with like hypertension and family history, at least annually they need screening by checking urine albumin creatinine ratio and eGFR. And despite this elaboration by international guideline, developed country like USA, less than 50% they are screened. Other developed country in France, only 30% are screening. I would like to stress in when you do screening, we need to do both eGFR and proteinuria, which is very important. In fact, in the classical model of CKD, type 2 diabetes progression, the onset of moderate to severe increased albuminuria precedes the drop in eGFR. As you see here, after we detect the GFR as well as proteinuria, we classify the patient based on KDOQI guideline heat map, where the vertical based on eGFR from class 1 to class 5, and the horizontal line is the degree of proteinuria. And as you see here, patient with heavy proteinuria, we classify them moderate to high risk despite the eGFR is still within accepted normal level. In 2012, we have the KDOQI guideline. And since then, we don't have anything till 2 years back, or 3 years actually. In 2012, we only do what we call conservative treatment. Apart of adding RASI, we do optimal control blood pressure, optimal control of hypertension, avoid nephrotoxic medication, diet control, lifestyle. However, for the last 2-3 years, we have updated guideline with emerging new treatment. In 2022, we have this, and 2024, we have this, where holistic approach need to be taken in consideration to delay the progression of CKD, and that leading us to introduce what we call now pillar in management of CKD. In addition to RASI, we have now SGL2, we have non-steroidal MRA, and we have GLB. So, 20 years or more back, we only use RASI based on several data elaborated their benefit in renal protection. We have renal study where losartan showed benefit, and we have also losartan in IDNT study, again showed benefit in renal protection. But despite we using those for the last 20 years, we still see patient progress to CKD. We have residual patient progress to CKD and require dialysis. Therefore, we need some treatment to delay the progression and to protect the kidney more and more. And now we have the pillar. We have SGL2, which came approximately 4 or 5 years back. And the role of SGL2, as you know, it's a proximal tubule, the SGL2 receptor. And once they block it, the sugar will be excreted in the urine. Furthermore, there will be salt coming in the ureter. The salt will touch the macula densa, and that will cause a tuberovascular feedback, and that will end up by afferent vasoconstriction, subsequently will decrease intraglomerular pressure, and a long term will improve eGFR. That's the main mechanism we thought for SGL2. However, there is a lot of mechanism coming in the board. They thought to be anti-inflammatory, anti-fibrotic. They work on dysfunctional mitochondria, as well as they have endothelial dysfunction benefit. There are 3 major studies were conducted for SGL2. The first one was in 2019, where CANA and Credence study showed benefit in patients with CKD and diabetes. Later on, we have 2 major randomized control studies about IMBA and DABA. Both of the studies, the importance for them, they included patients with CKD non-diabetes, where the benefit come for SGL2 and where introduction with them as a pillar for CKD, irrespective they are diabetes or non-diabetes. And the 3 major studies in randomized control on top of RASI, they showed renal protection. Therefore, they have grade 1A in added to guideline either for kidney as well as for the heart. One thing to remember about initiation of SGL2, after initiation of SGL2, because of aberrant vasoconstriction, there will be dip. The eGFR will drop in early stage, but this is nothing to be concerned about it, because this is their mechanism. And we say the more deeper, the benefit in the future. But later on, the curve will be separated, and the people who receive SGL2, they will improve eGFR, as you see the sloping of the curve here. Other pillar is non-steroidal MRA. First of its classes, it's finerenone, as you know. If you go for the pathophysiology of CKD in diabetes, it's driven by three main mechanisms. The first one is hemodynamic, that's intraglomerular pressure. The second is metabolic, where poorly controlled diabetes. And the third one is inflammatory process. And once you have inflammation, you will lead to glomerulosclerosis, tubular atrophy, mesangial expansion, and ended up by fibrosis of the kidney. We can target the intraglomerular pressure by the antihypertensive medication, mainly ACE, ARB, and lately SGL2. We can control diabetes by different agents, including insulin and others. What about inflammatory mechanism? In fact, before there were some trials to target this, but wasn't successful. Till recently, where the theory behind it, overactivation of mineralocorticoid receptor will lead to increased pro-inflammatory and pro-fibrotic agent like interleukin and cytokine. When those increase, that will increase fibrosis at the level of the kidney and heart, and ultimately causes fibrosis of the kidney, which is, again, it's a hallmark of the end-stage renal disease of CKD, irrespective to underlying pathology. So if we targeted this mechanism of action, we may halt and decrease the progression of CKD. So the role of non-steroidal MRA is a blockade of overactivation of mineralocorticoid receptor. Once we block that, that will decrease the interleukin and cytokine and will decrease the inflammatory process at the level of the kidney and protect the kidney further. This was a study, again, in randomized controlled trial, two major studies, Fidelio and Figaro. Fidelio was first study conducted basically for the kidney, where recruited different stages of the kidney between stage 4 to stage 2, with different degree of proteinuria from mild to moderate to severe. Again, the disease in comparison to placebo, it showed significant renal protection and slow the progression of CKD. Third of the classes of the pillar is a GLB. About 1 year ago, semaglutide in randomized controlled trial showed it's effective in slow the progression of diabetes with CKD. What they did, they randomized approximately 3,500 patients with mean age of 67 either to receive semaglutide or placebo on top of standard care of therapy, that's RASI, and some of them were also receiving SGL2. And the study after 3.4 showed there is significant reduction and slowing in kidney progression, and therefore the FDA approved semaglutide as first GLB in protection as a pillar for progression of CKD. Based on those all randomized controlled trial, the guideline, either diabetic guideline, cardiac guideline, or kidney guideline, they emphasize to use all those medications as cardiac and renal protection beyond their glycemic control. What's the future? Now we're looking for endothelin A receptor antagonist. When you activate endothelin receptor, that will lead to progression and fibrosis of the kidney. So if you block that, you may regress the kidney. Endothelin was showing some benefit in IgA nephropathy and now added to guideline actually in IgA nephropathy. Also, there's a study in FSGS as well as in diabetes. And there is a study almost in final stage where endothelin A receptor zibotentan in addition to SGL2 dapagliflozin demonstrates significant albuminuria reduction in patients with a chronic kidney disease and proteinuria. Other thing, aldosterone synthetase inhibitor rather than aldosterone blockade. So as I mentioned earlier, activation of aldosterone will increase fibrosis as well as inflammatory. So if we avoid synthesis of aldosterone to start with, that may achieve benefit in terms of renal protection. Now, aldosterone synthetase control the synthesis of aldosterone. We have baxdrostat. It's a highly selective, a small molecule which inhibits synthesis of aldosterone. a phase 2 trial ongoing, and as well as a phase 3 trial ongoing, and we anticipate some result in near future. So my time is finished. I have just one thing to add from clinical and practical point of view, how to deal with those medications, to introduce them. There are different ways to deal with them, but I think you need to individualize the patient based on the scenario of the patient. Patient with high risk cardiorenal, you introduce them early, about 2-3 weeks, and would monitor renal function as well as the potassium. Thanks. Oh, okay.